Okay. Good afternoon, everyone, and welcome to today's meeting for Adult Health and Active Lifestyle Scrutiny Board. My name is Councillor Abigail Marshall-Cutting, and I am the chair of the board. Lovely to see you all again, and it will be nice if we can have a quick introduction, just to also let you know that today's meeting is being webcast on the council's website so that any interested members of the public that are unable to observe in person will be able to observe remotely. So I've introduced myself and I'll start with Angela.
Good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor to the board.
Good afternoon, I'm Norma Harrington, Ward Councillor for Wetherby.
Good afternoon, everyone. I'm Councillor Caroline Anderson, a ward member for Adel and Wharfdale.
Hello, and I'm Councillor Graham Latty for Guiseley and Rawdon Ward.
Hi, I'm Councillor Winkage representing Morley South.
Hi, Councillor Conrad Hartbrook representing Rothwell.
Hello, Tim Riley, Chief Executive Leeds CCG.
Hi, I'm Sam Prince. I'm Director of Operations at Leeds Community Healthcare.
Hello, Victoria Eaton, Director of Public Health.
Kath Roth, Director of Adults and Health for Leeds City Council. Hi everyone, I'm Councillor Fiona Venner. I'm the Executive Board Member for Children and Adult Social Care, Early Years and Health Partnerships.
Hi everybody, I'm Councillor Salma Arif and Exec Member for Public Health and Active Lifestyle representing Gipton and Hare Hills. Thank you.
Good afternoon, John Beale. I chair Health Watch Leeds and I'm a co-opted member of this board.
Afternoon, I'm Lou Cunningham, one of the Armley Ward councillors.
Mohammed Iqbal, Councillor for Hunslet and Riverside Ward.
Good afternoon, James Gibson, Councillor for Crossgates and Winmore Ward.
Good afternoon, Councillor Taylor for Chapel Allerton Ward.
Hello, Harriet Spate, Governance Officer.
Thank you all very much and thanks for coming. Harriet, if you just stay there and just go through items 1 to 5 for us. Thank you.
Thanks, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item number 2, there are no items for exclusion of the press and public today. Under agenda item number 3, there are no late items of business. Under agenda item number 4, can I please invite board members to declare any interests? Take that as none, thank you. And item number 5, apologies. We've received apologies from Councillor Dowson today. Thanks, Chair.
Thank you very much. Okay, now to the minutes. I must say I'm sorry I was unable to be here on the 5th of October, but to say big thank you to Councillor Scopes, who did a very good job. I did watch it, so thank you. Right, can I ask to approve as a correct record of the minutes of the last meeting held on the 5th of October 2021? Yes. Okay, excellent, thank you. Right, straight to agenda item number 7. So having previously discussed the implications of the new health and care bill in context with our board, we did agree to maintain a watching brief regarding the development of the local integrated care system. We're pleased to have Tim with us this afternoon, and I believe you've got a presentation for us as well. So over to you, Tim.
Okay, thank you, Councillor, and thank you for the opportunity to come and update you on the work that's happening both across West Yorkshire but also within Leeds. I think it's important to say we're now in a period of stakeholder involvement that runs through November, December and into early January. Unfortunately, just the timing issues that commenced on the 8th of November, which was just after the papers would have come out for this board. So we've scheduled the sort of full and more detailed consultation on the constitution of the Integrated Care Board for the January meeting. So the full papers and so on will come for that. But I thought it'd be good to give you a bit of an update and a sense of where we are for now. So just got a few slides to go through, if that's all right, Angela, when you're Okay, thank you. So if we go to the second slide, if that's okay. Thank you. So, and we will obviously make sure that people are aware of these. What this these slides show, this slide is, if you like, a bit of a description of all the nomenclature and names and things within the ICS, but also some of the important flows. So they're at the top right-hand corner. You will see that there are health and wellbeing boards. That's the health and wellbeing boards of the 5 places in West Yorkshire, including, of course, the Leeds Health and Wellbeing Board. And very importantly, I think, the arrows go in 2 directions from those boards. Those boards shape and inform the integrated care partnership at West Yorkshire, and they inform the Leeds-based equivalent committee. If I talk a little bit about the first one, which sort of runs across at the top. So the health and wellbeing boards will play an important part in informing and shaping the strategy of the whole of West Yorkshire. And that will be held and owned by the Integrated Care Partnership Board, which is the top left on your screen. And that board already exists. We've been meeting for a number of years across the ICS in a partnership forum. It meets on a regular basis. It involves a multitude of partners, both from the NHS, local authorities, third sector, and that will continue to meet and continue to be chaired by Councillor Swift currently from Calderdale. And that board sets the overall strategy and direction for the partnership. I suppose just from a Leeds point of view, let's not lose sight of that important arrow from the Health and Wellbeing Board into that, because to me, that's where the understanding and the knowledge that will create the right strategy needs to come from. And then if we keep going round down to the left, what you'll then see is the Integrated Care Board. And this board will be, if you like, the sort of statutory body, the new statutory body that's coming through in legislation. It's where the money will go for the West Yorkshire system, at least initially. There's a whole set of requirements, although I have to say much more permissive than many of the previous changes in NHS legislation. And that board's membership will be made up of representatives, not just of commissioning, but provision as well, and not just of NHS people, but there'll be a place for the local authority, a place for the third sector on that board. That board then will operate, will have a number of statutory typical subcommittees that you'd expect around remuneration and audit and so on, which you can see on the bottom left there. But really importantly, from a Leeds perspective, and indeed for the other places in West Yorkshire, it will set out through its scheme of delegation to a Leeds committee of the ICB. So that committee will be made up of Leeds people. It'll be partners and providers, and I'll talk a little bit more about that in a moment. And it will take responsibility for the NHS resources coming into the city, and it will look to do that in an integrated way, as we do currently with the local authority in terms of things like the Better Care Fund and so on. At the same time, it will be accountable for delivering the requirements that the NHS has, that we've set out through our partnership strategy at West Yorkshire. And also importantly, it will take the steer from the Health and Wellbeing Board on our strategy, as we do now in the NHS and across the whole city, at the Health and Wellbeing Board and its strategy. So those are the key component parts, if you like, of the new system. And there will be some necessary subcommittees of that in order to, again, manage things like finance, investment and quality assurance and so on. I think in terms of the consultation, or the stakeholder involvement process that we're going through and the engagement that will happen through November, December and January, what we're really looking at is the constitution of that ICB board at West Yorkshire. That'll be set, so again, statutory requirement has a constitution, and that constitution will be made available, and also importantly, the scheme of delegation. So those are the bits that we are effectively engaging on, and we'll talk about in more detail in January at the Scrutiny board when I come back for that. So if we go on to the next slide, and then that'll just take us through a bit more into Leeds. So you can see on the right-hand side here in the blue, and I'm going to deliberately not worry too much about the detailed writing, but on the blue, you can see again that the committee in Leeds, the Leeds ICB committee, and at the bottom right-hand corner, you'll see the ICB board and the delegation and accountability between the two. That committee in many ways replaces the CCG governing body. However, it replaces it with a markedly different membership in that it involves wider partners, local authority, third sector, and also the NHS providers in the city. Whereas before the CCG governing body, with the exception, I think, of Victoria, Director of Public Health, it was mainly made up of independent members and GPs. Importantly, is the line from the Health and Wellbeing Board again via its strategy, which should steer that. So I think that's a really important piece. All the bits in green are what we already have running in Leeds. That is not an exhaustive list by any means. There are dozens of other committees, boards, partnership working that we do as a city. In some ways, they're just indicative of the types of thing that we do throughout Leeds. So what I suppose I want to say in many ways is that the world probably won't change that much in terms of real delivery. What is exciting and a great opportunity is bringing a broader collective group of people together to give the oversight to that process from an NHS ICB perspective. However, we don't want it just to be seen as NHS, because I don't think it should be, for lots of very good reasons. So in terms of where we've got to with that, we've broadly agreed that architecture that's described there, and we are some way on to developing the membership of that committee. In terms of where Scrutiny fits, really importantly, Scrutiny continues to look into Leeds and do the job you do now, both with the NHS and local authority. And I don't see in many ways that will change. People like with me and colleagues sat here will continue to attend on the issues that affect Leeds. Where I know there's conversations going on is how the best to manage those bits that are managed at a West Yorkshire level. We already have that sort of some joint arrangements, but I think it'll be important from a Scrutiny board point of view in Leeds that you will want to hold the ICB accountable just as much as, and give that oversight just as much as you do the arrangements in Leeds. So I've not drawn that on there, but it's very much there as a sort of, I almost want to put an arrow encompassing all of that, just as you do now. That was slightly beyond my PowerPoint skills at this stage. Should we go on to the next slide, please, Angela? Thank you. So just a little bit about the partnership, the membership of this. Some of this is set out in national guidance and mirrors what we would see as the ICB board itself. So in taking that delegation, we need to mirror some of that. So there will be some independent members. We very much want Health Watch to be part of that, and John has kindly agreed to be on that committee. And then there will be the Leeds partners, which includes the local authority, Director of Public Health, and the Director of Public Health, and also NHS providers and a representative of the GP Confederation, and importantly, the third sector. And then there'll be some officers of the ICS who will be Leeds based. So that will be sort of me, probably redesignated, a finance person, a nurse, and a medical officer. And there will be an independent chair, because one of the important things about this committee is it'll be holding some of the contracts with provider colleagues. And from a conflict of interest point of view, it's really important that the chair is seen to be independent of those providers. And of course, it will also be able to co-opt members and make other arrangements, but I'd rather it did that rather than we prescribe ahead of time where that might be. One of the important things we are looking around that is certainly at a West Yorkshire ICB board level. We are very keen that we have someone from the Race Equality Network as an attendee, and I think we'd probably want to mirror something similar in Leeds, but those are still ongoing discussions. So final slide, just briefly on sort of where we're up to in terms of process. So as I mentioned, a period of stakeholder involvement that commenced on the 8th of November. That's around the ICB constitution and the scheme of delegation. Put the link in there. We'll clearly bring that back in detail to the January meeting. And we'll continue to develop those Leeds place-based arrangements and again share those with you in detail for January. So yeah, I'll stop there if that's okay.
Thank you very much, Tim. Before we take questions or comments from the board, do you have any contributors that would like to say anything to your presentation? You're all happy with what Tim has said. Excellent. All right. To the board now. Yes, Dr. Bill.
Thank you, Chair, and thanks to Tim for explaining some of the nomenclature, because it seems to have changed over time, and keeping up with exactly what each committee is called is always a full-time job. You've indicated the representation of public health at the Leeds-based level. What representation, if any, is there from public health at the West Yorkshire level?
Sorry, Victoria may know the answer better than I do. Public health will certainly be involved in the integrated care partnership, and my understanding is, and it's set out that there will be a representative on the board of the integrated care board. How you have a board, it's very, very odd. We don't like the language, any of us have got to be honest. Calling an organisation, which is what the ICB is, an integrated care board, and then having a board of it as well, is just very difficult for anyone to get their heads around. But yes, public health should be absolutely through. I don't know, Victoria, if you want to add to that.
Yeah, just very briefly. That's also my understanding, John, that there will be a kind of a place around the table for a public health kind of colleague at West Yorkshire level, but the detail of how the detail of that and the links to the rest of the system, I understand, are yet to be worked out. I'll just add that we did have some conversations with West Yorkshire ICS colleagues last week to try to look at how on earth does this work with the public health system, and how can we be quite proactive around that in West Yorkshire. So they were really fruitful conversations. We have a workshop in January to work through more of that. Nobody's cracked this nationally, so I think we are. My sense is, and my understanding is, we're ahead of the game in having those conversations in West Yorkshire. But we need to work that through. I think in general, what we felt is that we've got a really good public health system that works from very localities right through at a Leeds level, and then right through to a regional Yorkshire and Humber level with the new public health arrangements around UK Health Security Agency and the new post PHE arrangements. But the bit that feels less developed is the West Yorkshire part of that. Because it's so very new. So all 5 West Yorkshire Public Health Directors of Public Health are actively involved in those conversations. We're all very keen to make sure that we get that right in terms of that two-way relationship with us as place as well. So we're really invested in that next step of those conversations, and so it feels very positive, but the detail's not there yet, John. But appreciate your question. Thank you.
Thank you, Victoria. Councillor Latty.
Thank you, Madam Chairman. In the sort of opening few words of your presentation, you said nothing's going to change. Could you sort of expand, please? Because it doesn't seem quite right somehow.
Yeah, I think I probably said nothing is going to change too much, because, and one of the reasons for that is West Yorkshire is quite a long way advanced. In many ways, it's the model for what is being done nationally through legislation. So clearly the CCGs won't be there as a statutory body, but many of the functions and things that we do will continue to be operated and done. They'll be done through that committee that I described, that place committee, and through the ICB board. So it's not that there will be no change, but I think in terms of on the ground and the kinds of decisions that we will make in Leeds, and the conversations that we would have at many of our partnership forum, which are both mix of sort of boards and other groups and meetings across the city, those things will continue to run, continue to be funded. An example might be the CCG is a sort of key funder of the Academic Health Partnership. And you might envisage, well, okay, the CCG is disappearing, where's that funding going? Well, the funding will carry on. I mean, these academic health partnership will continue to exist, funded through the NHS and the council and the universities in partnership. So I think at that level, we will not need to change anything significantly. Now, what we might choose to do as Leeds is continue to evolve and develop those things. But it goes back to West Yorkshire has been operating more or less in this kind of way now for quite a while, is an exemplar model of how the ICS legislation is envisaged. So I hope that's helpful.
Are you? Oh. Okay, Councillor Gibson.
Thank you, Chair. I think Dr. Beale sort of asked my question, and the answer may be that there is a place for public health on the West Yorkshire board, but I'm going to ask the question anyway, so to be a little bit more explicit. So, having read through the Act, there's it says there's a duty to have regard to the need to reduce inequalities between patients, and as part of that, I'll quote, to promote integration. Now, it's my understanding that actually there's not really that much of a change in terms of how this bill's been written between the 06 NHS Act and the 2012 Health and Social Care Act. So that sort of provisions always has been there with us for a long time. But my question is there a new emphasis now, given the context in which this legislation was written, and therefore given the spirit of the Act, to work more closely with housing, public transport, education, etc., to reduce health inequalities? And I think it's worth saying as well that this bill, it seems to me to have missed an opportunity to be explicit in its recognition and encouragement of the wider role of the NHS to play its to play a role as anchor institutions. And what I mean by that is the NHS agencies, due to their size and scale and rootedness in the communities, could and should potentially influence social and economic and environmental factors that shape health inequalities. But I'll go back to that, to the main question: is there a different spirit, and as a result of that, have you looked at housing, etc., that I've just mentioned?
Thank you, Councillor Gibson. Really helpful question. There is a different spirit. I struggle when I read the legislation to tease out whether the spirit that is it definitely feels different in Leeds and West Yorkshire is a Leeds and West Yorkshire feel, or whether it's really there at the heart of the legislation. I do believe the intention is there. One of the key requirements in there that is a shift, and I think it links to that anchor institution piece that you also rightly draw attention to, is the expectation that NHS providers will now have a very specific duty around what we call the triple aim, which is this aim around improving outcomes, improving quality, and improving efficiency. Now, quality and efficiency are bread and butter of what NHS providers have always done. But I think that expectation now around outcomes for the population, and it's very explicit, it's about the population, not just their patients, is probably a really quite a significant shift that's easy to miss. I suppose the other thing I would say is that I don't think legislation can only go so far. What we then choose to do with it, both within Leeds and indeed West Yorkshire, is up to us. I think this does give us opportunities. We've got a fantastic health and wellbeing board, a really clear health and wellbeing strategy, which is coming up for a refresh. And very much at the heart of that, and linking through to things like Marmot, we're going to want to be broader in tackling some of the causes and drivers of health inequality. And in doing so, the NHS will want to play its part, which is where the anchor institution piece comes in. So I don't think the legislation forces that, but it certainly creates the opportunity, and we will want to take that in Leeds. Now, I would look first to the Health and Wellbeing Board to make those connections, but there are plenty of places where we are already, I know we're starting to do some of that work in quite a lot of detail. And the anchor institution programme in Leeds is good and well known nationally, and something I would want us to really press on with. So yeah, absolutely support your comments. Probably is a bit of a missed opportunity. The legislation could have been a bit tighter on some of those things, but it certainly doesn't inhibit what we want to do.
Thank you very much. I'll come back to you, James. Councillor Cunningham needs to leave soon, and she's got a pressing question, so I'll let her take.
Thanks, Chair. Thanks, Tim. Mine's just a very brief question. I know you touched on the amount of involvement by external boards and third sector. I just wonder, with this framework, how much the decision making in terms of funding allocations and procurements is actually changing. So is it going to become more of a kind of top-heavy decision-making framework? Thank you.
Thank you, Councillor Cunningham. I do think that's why looking at the Integrated Care Board constitution is really important, and the delegations and the scheme of delegation. What West Yorkshire wants to do, and again, the legislation is quite permissive, so this isn't a guarantee, but certainly West Yorkshire wants to take this opportunity, is to ensure that as much as possible takes place at place level, Leeds level or Wakefield level. And in doing that, I don't think we are moving away from the direction of travel, which has been one of taking those decisions more and more locally. So in terms of where sort of contracts and big decisions about the money are made, at the moment, in a sort of formal legal sense, the NHS money comes through to the CCG, and the CCG will sign off its budgets and so on for the year ahead, and indeed have a medium-term investment plan sat behind that. In the new world, the people who will be signing off those budgets is that broader coalition of members on that list that I put up, which includes the third sector. In a way, they're not on the current CCG board. It includes local authority, it includes the NHS providers. I think that gives us huge opportunities to look at the totality of the picture. There's some challenges in there, competitive, but it's the right direction, and it is building on what we've already been doing in Leeds. So whilst formally the CCG sets that budget, behind the scenes, the work between officers is to go around and talk to everybody and try and set that in a collegiate way, so that we aren't sort of scrapping over the pennies, which has been working really well in the last few years. So this to me is the next step on that, and it is coming to Leeds. Most of that currently NHS budget of circa 1.4 billion will be coming into Leeds, into that committee of the ICB. Okay.
Thank you very much. Councillor Gibson. And then Victoria.
Thank you. You've sort of answered it, Tim, really. I mean, the legislation says that the ICB only has to have regard for the ICP, doesn't it? So it's all about, as regard to, have to have regard in terms of the strategies of the ICP, be informed by that. So it's very loose, isn't it, the term, and it's all about leadership. But you've sort of answered it in the sense that there's an opportunity within the formation of the constitution for the ICB to sort of have to enshrine that we do pay more than just lip service to the ICP. But it sounds like that's what you're looking at, the direction that you're going with the constitution anyway.
Yes, yeah, certainly West Yorkshire is really keen that we don't pay lip service to that partnership forum, which is the ICP. And there are some sort of small examples of that. Whilst we can't make the chair of that board a member of the ICB board, in our constitution we set out there'll be a formal attendee, which I think in itself says a lot about our intention. At the same time, we are building on what we've been doing for 2, 3, 4 years, where that strategy that we set at a West Yorkshire partnership level with its 10 most important changes and priorities are going to be almost enshrined within what we do, and tracked by the board. So the board will take those from the partnership and track them routinely, and ask Leeds to track its version of them, and Wakefield and so on. So I believe West Yorkshire has got the approach right. If we can test that, we need to test it. But we are probably in a much better place because of what we've done already than some other places where it may well be lip service. And I think it's true of the Health and Wellbeing Board in Leeds as well, that we don't pay lip service to it. We're all very committed to improving the health of the poor as fastest, and those things matter to us all. That isn't the case in other places in England I've worked at in the past. So let's hold us to that, because that's an important challenge, and it's absolutely essential if we're to succeed for the people of Leeds and West Yorkshire more generally.
Thank you very much. Victoria.
Thank you, Chair. I just wanted to add a comment to echo what Tim's emphasised around local leadership, around the health inequalities question, Councillor. I think it's absolutely the right question, and it's been a conversation that we've had intensively over the last few months about how we make sure the health inequalities work that we want to happen across the city and across West Yorkshire is enabled by the new arrangements. And as Tim's described, that actually doesn't come through specifically enough in the legislation. It will come from local leadership and commitment. So I think that we've got a real opportunity to as leaders make sure that this happens locally. One of the things we really want to do is join up the great work that NHS colleagues are doing around their healthcare contribution to addressing health inequalities, which is one of the green boxes that was on Tim's slide before, with all of the work that the council and the rest of the third sector is leading across the rest of the city around housing, education, all the broad work we do in communities, and make sure that really hangs together for Leeds as a place. So we've had a lot of local conversations about absolutely being committed to that, and then also the relationship with Health and Wellbeing Board, with that central commitment to improving the health of the poorest, the fastest. The relationship to the board and how we continue to strengthen that is something that will come from ourselves as local leaders, and just to assure the board that that's at the centre of all of our thinking and planning. But it doesn't happen. It doesn't happen by default. It happens, and I think the fact that you've raised it and this board has raised it, is absolutely right, because we need to be held to account for that. I think the final thing to say that as a West Yorkshire system, the conversations have also been very supportive around those wider determinants of health and the role of the West Yorkshire organisation there. So there is a public health team at West Yorkshire in the ICS, which is why, just going back to the conversations I said we had last week, we need to really work out who does what and how that best works across us in the new arrangements. So it's not disjointed, and it does work well with the arrangements we've already got. So just to assure you, we're incredibly committed to, because we've got this window of opportunity to get that right. So very happy to come back and update on that in the future.
Thank you very much, Victoria, for reassuring us. Sorry, we will have to stop there on this particular item, but I would like to highlight that the Scrutiny Board will actually be focusing our January's meeting. We will be formally considering and sharing the views of the ICT constitution, as well as the Leeds place-based arrangements as part of the wider consultation process. So that will be in January of 2022, well, after you've all had a very good Christmas. So team, we will be inviting you back if that's all right. Thank you very much. Right, we're going straight to agenda item number 8, the impact of COVID-19 and the ongoing recovery measures across the local health and care system. Since the outbreak of the COVID-19 pandemic, the Adult Health and Active Lifestyle Scrutiny Board has maintained a key focus on how the council and its partners are working collaboratively to support patients, service users, and stakeholders across the health and care system during such an unprecedented and difficult period. So within your agenda pack is a briefing paper that has been produced in liaison with partners across the local health and care system, and this presents a further update on the current understanding of the system impact of the COVID-19 pandemic in Leeds, as well as providing an insight to the response plans and measures that are in place too. So I believe Helen is here. Hi, Helen, how are you? Good. Over to you now.
Thank you so much, Councillor. Thank you for inviting me. I'd like to thank particularly Neil Maguire from our Health Partnerships team, who has pulled together the paper. I think a briefing paper is probably a misnomer for a paper of this size. And apologies, because it is quite diverse and disparate. I'm delighted to welcome some colleagues here. Kat's here, Fiona's here, Sam Prince and Claire Smith. So we will do our best to answer questions. If the questions we can't answer, we'll of course come back to the board. I suppose I just wanted to give a brief introduction. I think you can see through this paper the very wide range of issues that colleagues are grappling with, and that we know that our citizens are grappling with and continue to grapple with 20 however many months it is in. There's some things I wanted you to note. I guess the extreme pressures in demand, which I think we talked about last time we were here, have not got down. If anything, they've gone up. We've increased capacity where we can. And those of you who were listening to the radio this morning will understand repeatedly that colleagues will emphasize that staffing remains the biggest barrier rather than short-term money. There's some good news in that we are now recovering some of the capacity in some of the areas. And indeed, there were more outpatient appointments in general practice in September than there were before the pandemic. And that our capacity in outpatients and diagnostics also picked up. But we need to be aware of the continued gaps in workforce and the impact of social distancing on the numbers of patients that can be safely seen in any of those settings. Outflow from hospital remains a significant concern, and I'm sure that Kath or I will touch on that afterwards. Social care workforce we've touched on in this report, but Kath again is now leading some very sort of intensive work across the city on workforce. We might want to pick some of that up. Important to note, I'm not sure it comes out in the paper, that pressures across particularly acute mental health services also continue to be significant, particularly among female patients, and acuity, not just volumes. Sometimes the numbers of admissions don't show what's behind it. So a number isn't a number of people come through any. Actually, the numbers of admissions have come down, but the sickness, the way in which those people are presenting increases their lengths of stay and their needs. There is a section in here around dental services provided by NHS England colleagues. I'm going to preempt the questions and just remind colleagues that we're not the Commissioner for Dental Services. So I'm really pleased that we've been able to include something. And I know Emma has offered to come back to talk about any of that in more detail. So I think those were the kind of introductory comments I wanted to make. I don't know, Kath or Fiona, whether I'm sure that Fiona will provide an update. I think the other thing about these papers is the minute we finish them, something changes. So very conscious that 3 weeks ago, this was the position. So there's some slightly better COVID news, which we might let Fiona brief you on. And then Victoria, God, sorry. It was a compliment. I'm so sorry, Victoria. It's been one of those weeks. I do know what I'm doing, really. So Victoria may be able to update on that, and I'm sure that Kath will pick up other issues. So that's probably enough for an introduction, and leave it to you to.
Thank you very much, Helen. Okay, who's going first before we come to the board members, contributors? Councillor Venner, are you going first?
I just wanted to make some overall comments on the paper, but I'm happy for Victoria to go for next if that fits better.
Okay.
Well, I'm more than happy just to give a very brief narrative on where we are today in terms of the COVID position. Obviously, it's very live. I mean, I'm just flicking through the latest notes. So in overall terms, you'll have seen, I'm sure, from the national press, the sort of that rates have dropped slightly over the last week nationally, but obviously from a very high base. So we've still got very high levels that have fallen over the last week or so. The position in Leeds is relatively positive with all of those health warnings around. It's still very high, it's still very early. We can't predict realistically beyond the next 2 weeks. We don't know exactly what will happen there. But in Leeds, we've gone under 300 now for our overall city rate, which is very positive compared to where we've been over the last month. The critical rate in our over 60s population has fallen even further. So that was down by 37% as 7-week average last night, which is great to see. Obviously, that's the rate we keep a particular eye on in terms of pressures into the NHS system and most severe health risk. And we're in a more positive position than the rest of Yorkshire and Humber on both those rates at the moment. So our rates are lower for both over 60s and over 70s actually, as well as the general population compared to the rest of Yorkshire and Humber, and also compared to the national England average at the moment. So as a city, even though we can never be complacent, rates are still high, they have fallen more steeply than other parts of the country. And obviously all of this plays directly into pressures on our NHS colleagues. So we can we can very accurately predict with the time lag when those rates in communities with around a 2-week lag then present to increased demand in the hospital particularly. So again, I'm sure colleagues will go on to explain that even though the COVID position is still higher than we'd like and still there in local NHS, it's not the numbers aren't what they were, because we've seen this rise in the reduction in community infections. So so at the moment, it's looking more positive. The projections ahead, we get projections ahead for the next set. It's a 78-day projection, which obviously is as far as the modelers can stretch, and that suggests again that downward trend, both in terms of rates and also in terms of the hospital numbers. So that's the kind of optimistic part of the picture. Obviously, COVID is one element of the pressure in hospitals at the moment. There's a huge sort of range of other pressures that are coming through that colleagues will describe. But every COVID case we can prevent and keep out of the system is helpful to support the overall pressures in the hospitals and the rest of the NHS. And obviously, the other thing we keep a close eye on is other respiratory infections, particularly flu. At the moment, there's very little evidence of flu with us. It's not hit yet. Obviously, the later that is, the better, because it means we can get our COVID cases down as far as we can before we see any flu. And we hope that flu will be, at a manageable and minimal level, which is why obviously the flu immunisation campaign is as critical in terms of take up as the COVID vaccination campaign at the moment. So that I'll leave it there. That's where we are in terms of particularly COVID, but just keeping an eye on flu as well as a particular pressure.
Okay.
Thank you.
Thank you very much, Victoria. Councillor Venner.
Yeah, I just wanted to make some overall comments on the paper and how various strategies that we have across the council and across the city are responding to the fact that we're in this context of the global pandemic. So obviously the paper outlines a huge range of impacts, and I think it's really helpful where it demonstrates the 4 waves showing the impacts across time and in a number of areas. So the paper refers to mental health. We've obviously got the all-age mental health strategy and Future in Mind, which is the young people's mental health and wellbeing strategy. I chair the Future in Mind board, and it was timely that the strategy was due to be refreshed anyway. So it's been newly refreshed this year, very much in the context of COVID and what that means for children and young people's mental health and wellbeing and for the pressure on services. There's also some references in the paper to comments Anne Longfield made, the previous Children's Commissioner, about child poverty, and we've also got Thriving, which is our child poverty strategy. And again, that's a group that I chair. And we've also refreshed that strategy particularly to bring in a new work stream around green space, because the pandemic so highlighted that children and young people had a very different experience. And it's a health inequality that was very magnified by the pandemic in terms of which children did and didn't have access to green space, and that being very linked to poverty. The paper refers to the joint strategic assessment, which is obviously really key in terms of that will give us the evidence we need to know where we need to direct resource and energy over the coming years. And also keeping the experience of people in receipt of services and in our communities and in our grassroots organisations that are serving those communities very centrally. So the Allyship Programme is referred to briefly, I think, which is where each member of the Health and Wellbeing Board, and this is very senior people, like Tim's on the Health and Wellbeing Board, Chief Executive Teaching Hospitals Trust, LWEP, PFT, LCH, every board member is paired with a small third sector organisation that's delivering work with communities that are facing health inequality. So I'm paired with GATE, the Gypsy Traveller Exchange, for example. So that's giving us all really direct experience of organisations that are serving our most disadvantaged communities in the city, and that will inform our planning going forward. Obviously, the workforce crisis is a massive issue, and Kath may want to talk about that in more detail, but it is ultimately about the fact that we're losing staff to hospitality and retail, and can't compete with their salaries. And we've had meetings across the system to look at how we address this, because it's a crisis now and we're not in winter yet. Okay, those are my introductory comments, Chair. Thank you.
Thank you, Councillor Venner. Councillor Arif.
Thank you, Chair. I just wanted to talk a little bit, because the report does talk a little bit about the vaccine uptake, and we know health and wider inequalities have been exacerbated by the pandemic, particularly in more deprived communities. And I guess what I'm trying to say is, whilst we've done a great amount of work with the vaccine programme, and we've made some really good inroads, there are still communities that we have got the uptake is lower. I mean, I'm just going to give an example. I went to get my booster done at the local walk-in centre, and I bumped into an old neighbour who's about the same age as my mum, and I said, "Oh, hello, it's good to see you here. Have you come for your booster?" And she said, "No, I've come for my first dose." So what that tells you is it's really important that we are still in those communities, because there are people that are coming in for their first dose. So I think we've got to still bear in mind that we've got to continue doing all the work that we have been doing, and we can't leave these communities that we know are most impacted by COVID behind. So I think from my perspective as exec member, and from what I hear, the appetite is very much still there, that we've got to continue with that piece of work, and it has to carry on. When the government support stops, we've still got to carry on doing what we need to do to protect our communities. I think it's important we talk about that. Thank you.
Thank you very much, Councillor Arif. For all those supporting, is that every brief you need to give? Have you given that? Yeah, are you ready for us to make comments and questions now? Excellent. Okay, Councillor Hatbrick, you go first.
Yeah, I'd be fascinated to hear more around where the groups are that are having resistance to taking up first or second or even tertiary vaccines. Is that education? Is it religious? Is it cultural? Or is it a whole mix of different things that are causing that? If you're struggling with other aspects of your life, maybe the vaccine isn't the top of your priority. So I'd be curious to understand that, because I think many of us kind of that do Facebook see, there is I see still quite a strong, what I would class as anti-vax, which is the whole kind of, well, let's not discuss it here, but the misinformation that gets peddled, but I don't necessarily think that that's necessarily the same case across the piece. One follow-up question. It was mentioned that Leeds is doing actually better with rates overall at the moment. Is that because we had a peak earlier on, or our cases overall across a consistent period better? That's all. Thanks.
Do you want me to pick up on those? I can start on both of them, but happy for others to come in. So in terms of our position now in relation to other areas, I mean, it's likely to be a combination of many things, and there's people disagree on the analysis of why. I'm sure you'll appreciate. I think. I mean, there's something really interesting happening at the moment with, if we looked at very local area maps of the places with the highest rates, what you generally see now is almost an inverse of what you saw earlier on in the pandemic. So earlier on, it was higher in, dense, more deprived inner city areas. It was really high. I mean, if people remember last October, when we hit the highest place in the country with Headingley, with our student population, with the rate there. So those groups, so our 19 to 24-year-old adults are currently the very lowest cohort for infection, probably because most of them have had it, or they've either had the jab or had the virus or both. And similarly with those communities who were kind of exposed very early on, immunity is higher than people in more affluent areas who have worked from home so far, been less exposed. So we've got this kind of strange thing happening at the moment where the communities who haven't had it so far are looking really high, but that will settle down as the immunity works through. So I think at the moment, because Leeds is a pretty young city, and the rate in that young adult group is the lowest, it kind of it plays out in our demographics that we are, you know, other core cities with a lot of university students sort of mirror the same pattern. Having said that, I think that another factor for us in Leeds is partly about our response, and the fact that we still have an incredibly robust response on the ground. We've never in the city had a large outbreak of the scale that many other neighbours have had in a big factory or workplace or whatever, because we have brilliant infection control team that is, you know, is preventing and managing outbreaks on very early cases. In our schools currently, we're in a much better position than other places with higher numbers of school cases and outbreaks, because we have teams out there risk assessing and advising all of our Leeds schools, and not everywhere has the capacity to do that. So I think it partly reflects our demography, but also reflects, as Councillor Arif has described, that approach that from the beginning we've been really focused on prevention. We've been very targeted on the groups that need it most. So I think, and that still goes on today. Teams are out there doing that today to keep the rate low. So it's probably a combination of all of those things. And I'm sure Councillor Arif or Sam will come in on the which groups, but I mean, in very broad terms, and we can certainly share some more detail on this with the Scrutiny Board if you're interested. We have a group that meets fortnightly every other Thursday called the No One Left Behind group, which looks at vaccine inequalities across the city. And we get very granular local data on exactly which age groups, which people from different ethnic backgrounds, which parts of the city, etc., have taken up the vaccine. So we can really track that very closely, and it's quite detailed information that we can certainly share that with the board. Broadly speaking, there's a declining uptake in terms of age. So Sam's got a brilliant slide that the further you go down the age groups, the lower the percentage of take up. We know that in our deprived communities, there's a lower take up than in our more affluent communities. And also where we have more ethnically diverse communities, there's a lower take up than with predominantly white British populations. So a combination of all that kind of plays in, but more than happy to share those latest figures. Chair.
Thank you very much. Yeah, that would be very helpful. I would really love to see those that data. Thank you. Councillor Latti, and then Dr. Bill, and then Councillor Anderson.
Thank you, Madam Chairman. We are, so I believe, heading towards the pandemic changing into endemic. And the only comparison that most of us have is with influenza.
Sorry, Councillor Latti, I'll just come in. Victoria, you need to turn your mic off. That's it. Thank you.
Right. I heard me, did you? So we have a comparison with influenza, and that is controlled by immunisation, basically. And we all accept that. We trot along every autumn, get jabbed and forget about it, and that's it. And flu, as far as most of us are concerned, isn't a dangerous thing. And then I read in the paper the other day the number of deaths from flu each year, and it's frightening. You know, it made to me it made the present pandemic seem a lot more in proportion, as you might say, which I'm not treating lightheartedly, but flu is more serious if you think in terms of deaths than most of us think it is. Now, we all live with this. We, as I say, we happily get injected and get on with our lives. I know that this pandemic is new, so to speak, but should there not be more effort to make us regard it as something that we are, all of us, working towards making endemic, so that we can all every year trot along again and get 2 jabs and carry on with our lives, which would reduce what has been quite a serious psychological effect on an awful lot of people. The fact of this thing sitting on our shoulder, waiting to pounce, when in actual fact, or this is how I see it from what I read, influenza isn't that far behind it in terms of danger, particularly to old people. So could you give me something sort of reassuring on that, or the fact that we are thinking of moving this way, that we do want to get people thinking this way, or am I just living in cloud cuckoo land?
Would you like me to start on that one? I'm happy for colleagues to come in. I don't know if Sam might want to say something. So yes, you're right, Councillor Latty, that there is a lot of flu deaths every year, and they don't get reported in the same way that the COVID deaths do, and on the evening news every night. So it's much less visible to people. One of the things that certainly we would always say, and certainly on a national level, the Chief Medical Officer would always say, is that the true figure of the impact of the pandemic is looking at the excess deaths from all causes. So, whether people have died from another cause because they've not got treatment as promptly as they could, or it's a COVID death. And even the definition of the COVID deaths, as you know, are measured in different ways. It's that 28 days after a COVID positive COVID test. It doesn't necessarily mean primarily that COVID was primary cause of death, etc. And from a registrar point of view, the definition is wherever COVID is mentioned on the death certificate, it's counted as COVID death. So there's all sorts of nuances around numbers and how we define them. But so I think there's something about us keeping as a system a really close eye on the overall excess deaths, which thankfully, because we get this every day, thankfully is now dipped below the 5-year average. It was way above, as a measure of how it's hitting our whole population. So I think that's something. And I think your point around, obviously moving from pandemic to endemic, as we know, there is a lot of talk about how we learn to live with the virus, and the fact that we're here today is an example of that, about how we all kind of maybe don't go back to the normal that was before, but think about ways that life goes on, education goes on with measures, work goes on with different measures. And so I think that it feels like the territory we are in. Obviously the unknowns for the future are potentially around new variants that may come in, that may have vaccine escape, and then actually the vaccines that we have won't do the job for next year. And but that's I think in terms of the planning for the different scenarios, that feels like that there's a sense of the fact that COVID's still with us. It's moving to more endemic levels. We can't predict it, but we need to get ready for how that virus may change over time. But actually that needs to run in alongside a lot of other business as usual for all sorts of other health issues that are hitting us as a city and as a country. So I think that is my sense of where we are, that this has completely overtaken all of our lives for the last 20 months. And now it's still with us, but there's a balance of how we manage it alongside everything else we have to manage. And I'm sure health colleagues would, support the whole thing about COVID just being one element of the pressures. So I'll leave it there. Thank you.
Shall I pick up? So we're already planning now for next year, and business as usual will be 2 vaccinations for COVID and for flu. That's exactly where we wanted to be this year, but there was a bit of misalignment in terms of vaccine supply, both flu and COVID, and also misalignment as to which groups will be targeted for vaccination. So the planning has started now, so that next year we go into the autumn winter period with everybody hearing the message about it's just as important to get flu as it is COVID vaccination. And we will do our utmost to make sure they could be administered on the same day, so it's convenient for people as well.
Are you happy, Councillor Latte?
So one of the things I was getting at is, should we be more heavily educating us all into a different way of thinking, or do we just accept the status quo?
Hello, I'm Claire Smith. I'm the Chief Operating Officer at Leeds Teaching Hospitals Trust. I think that's a very difficult question to answer. We're clearly learning a lot about this disease, and we've been learning a lot about it for the last 20 months at pace. And I think if we think about how long flu has been around and our ability to prepare for that, and every winter, as you know, councillors, winter is a huge challenge, not just for the NHS, but also for our social care colleagues as well. And when we consider at the moment, LTHT has currently got, well, we're now down to 3 wards that are fully COVID positive, plus patients in critical care. That is in addition to the work that we would normally be doing and the preparation that we would normally be making for flu. So I think because of it's the intensity of the time frame of learning, the intensity of our ability to respond. And I think we are certainly, until we get over the hump of this winter, which I have to say is of concern because of the level of unknown about flu, because of course flu last year was so very low because of we were all isolating and not interacting with each other. So we really don't know what the progression of either of those two were going to be over the course of this next 6 months. So I think that question will be easier to answer perhaps. It's probably a bit of a cop-out, but probably easier to answer in about 4 or 5 months' time.
Thank you, Victoria.
Councillor Latte, just to briefly come back on that last question, I think that as we've gone to this point in the pandemic, it feels now there's much more of a conversation about balancing different risks to health. So obviously in the height of the pandemic, you know, the overarching focus was on COVID. I think as we come through to where we are now, there's something about how we talk with the public around what they can do to protect themselves from COVID. Obviously, take the vaccination plus all the other measures to keep yourself safe. So we need to continue to do that. But what's been really interesting is that for the first time in a long time, lots of people have been interested in public health, in vaccination, and in inequalities as well, about being quite shocked around the inequalities that COVID's brought up. And I think that if we look at all of our vaccination programs, we have identical issues about poor uptake in the same communities. So there's an opportunity here to take the learning from COVID and actually say, you know what, childhood immunisations are incredibly important. We know we every year we get low uptake from the community, from these communities. And how do we keep that? How do we keep that intense focus going beyond COVID for lots of other things that have a huge impact on health, and use the learning and share the balance of risk? And I think the part of the other dimension of that is about other risks to health, which aren't other infectious diseases, but are around, say, the whole debate about getting kids back into school, even though rates have been high, because actually it's more damaging to long-term health for children to miss education and their impact on their mental health, as Councillor Venner raised before. We know we're seeing other implications of being one-dimensional about COVID. We've got to see it within that wider risk of other issues around the public's health. So I think it will be, which is partly the conversations we're going to bring back around some of the work we want to do around health inequalities and how we move on from COVID towards the challenges that we now face, looking much more broadly at public health. So I would really take in I think part of your question was around how we balance this with other risks. So I'd be really keen for us to constantly look at COVID in the round and think what we can draw on and learn from for all of our other public health issues.
Thank you very much, Victoria. Dr. Bill.
Thanks very much, Chair. I mean, I think the first thing to say is to thank all the NH staff and all those who work in social care for what they've been doing over the last 18 months. And indeed, those people who are unpaid carers as well, because my buddy in the Health and Wellbeing Board is actually from Carers Leeds. So I think that we need to understand that a lot of support has come from people who actually care for others, including school children as well. Very important to say. So that's the starting point. Mention has been made of the media and indeed on the Today programme this morning on Radio 4. So I'd like to ask a few detailed questions about how we're doing in Leeds compared with what we hear on the media elsewhere. And the first is A&E. We learned from the papers, and also thanks to whoever prepared this document, which was very helpful. And a large increase in the number of people turning up in A&E. And we hear of people having coronaries, having strokes, sitting in ambulances for hours on end before they can even get in as far as A&E, let alone sort of definitive treatment. So the question on that is, what proportion of patients to A&E, say in the last month in Leeds, have had to wait more than 4 hours, which is the sort of target? I know targets are not terribly popular, but it does give us an indication of what people could expect from the NHS, all things being equal. So first of all, what proportion of patients have to wait more than 4 hours? Secondly, we were really getting on top, I think, of the situation before COVID in terms of reducing the number of delayed discharges, what were previously known as bed blockers. People who didn't need hospital care anymore, but couldn't go back anywhere else because they couldn't go home because they didn't have the right support, or they couldn't go into residential care because there were no vacancies which could support their needs. So how are we doing in terms of delayed discharges in this city? And thirdly, and I am sad that again, NHS England are not here, but I'm not going to let dentistry escape totally, because it's not only primary dental care, there's also secondary dental care. And so it does involve the hospital.
Yeah.
And as many of you know, the most common reason for young children going into hospital for admission is to have decayed teeth taken out because they've got toothache. So I wonder what the current waiting time is for young children, 4-year-olds, 5-year-olds, suffering from toothache, having to wait till they can go in and have a general anaesthetic to have those teeth taken out. And lastly, Chair,
that's a lot of questions, Dr. Bill. We have two
Shall
others that are,
yeah,
you hold on for
point?
now.
I'll
Yeah, and
stop
then
at
so that others can ask your
point.
questions. Thank you.
That's fine, thanks.
Shall I start? So just from the perspective of ambulance, so we're doing very well within Leeds in terms of our ambulance handover, and I'm pleased to say there's been no patients that have waited longer than 2 hours for handover within the city of Leeds. And the majority of patients, we are able to do a transfer in less than an hour, and our target is 15 minutes. That is what we aim for, to have a handover within that time, and we're one of the best in the country, certainly in the upper quartile for that. It's a real priority for us because obviously with the size of Leeds in both LGI and St James's, if we're not able to retain that, then that holds up ambulances for the rest of West Yorkshire. So we really do really focus on that. In terms of our A&E position and delivery of the standard within 4 hours, we're in, I'm afraid to say, in the mid 60% for that at this point in time. But that still places us. So for the last week, for example, we were 61 out of 123 trusts who report in the country for our standards, and that shows, I think, the level of pressure that's been experienced in the NHS across the whole of the of the country. We have a huge amount of work, as you would expect, in order to be able to reduce that, from an admission avoidance, from an attendance avoidance, all sorts of different things, which I'm more than happy to share at a future point. And we're making some really great strides in terms of our same day emergency care offering at both sides of the city as well, which I'm really pleased with, which is being supported by all partners that are around this table today. From a delayed discharge perspective, we have seen an increase in terms of the number of patients, although that is at the moment in terms of patients with no reason to reside, around 220 patients within the hospital today. That does have an impact on the hospital, but also because of the acuity that we're seeing across the whole of health as well, which means that our bed occupancy level is running extremely high. So that level of pressure is felt, and I'm sure Kath and colleagues will are happy to expand on that further. But we are internally doing a lot of work to try and ensure that we are preparing our patients, our citizens, as early as possible for discharge, and that they are informed and engaged in the discharge process as well. From a paediatric dentistry perspective, so it's difficult to answer that question. So unfortunately, we do have some patients that have waited nearly 2 years to have some treatment in paediatric dentistry, but they will be classed as routine, so they've all been clinically triaged. So those patients that are more urgent will have their appointment far earlier than that. And we're using a really clear classification of priority that's been issued by Royal Colleges of Surgeons and the dental body as well. We were significantly impacted in dental services, as you know, because it was an aerosol generating procedure, and we've invested hundreds of thousands of pounds in additional drills now that actually it's very fancy and kind of sucks it all out, so that it's not the tooth, the air, to try and increase the number of patients that we can treat. There has been an impact in terms of community service, and there's a number of services that have not been able to continue to provide, which has meant that there's been a greater level of referral into the acute trust. And we're continuing to work with colleagues in NHS England on that in order to be able to put alternative provision in place across the city of Leeds. So it is a challenging position across all of the domains. However, we have seen some exemplary work coming from our clinical teams, from our partners across adult social care, and also community partners as well. So I think we, just going back to the previous point from Councillor Latte, I think a lot depends on how this winter is going to go in terms of how those numbers bear through. But certainly from an ambulance perspective, which was the start of your question, we are absolutely focused on maintaining those handover levels.
Thank you very much. I would like Angela to just give an update quick on the dental plan that we have for January, so that Dr. Bill will be rest assured that we're definitely not letting it go.
Thank you, Chair. Yeah, just to reassure members, we have had that direct liaison with NHS England. They did relay apologies in terms of being able to attend this meeting, albeit that they did make sure that they informed the briefing paper. But on that, they are also keen to come to a future meeting, perhaps early in the new year, so that we can actually look at this in greater detail, because I know dentistry has come up quite a few times in discussion. So whereas they did help inform that broader COVID impact paper for today, we are looking at arranging a date where we can look for just focus on dentistry.
And I've had a pre-meeting with them, so don't worry, we'll bring them back. All right, good. Okay, Councillor Anderson.
Thank you, Chair. I'm more than concerned about children with bad teeth. Really, we should be looking at why, not what building up cases for the service. We should be trying to avoid them having to be on a waiting list. And what on earth is happening with children's teeth? Anyway, that wasn't my question. Do we know how effective this year's flu jab concoction is going to be? I mean, has it actually been tested in reality? Are we just not in the flu season yet, or is it a complete coincidence that we haven't got any flu, or is it due to people, more people getting the flu jab this time round? That's my first question. I've got some other ones. Shall I? I've got 4. Oh, okay. So my other one was to do with the flu jab again. What's the historic take-up of the flu jab flu jab across deprived and BAME communities. Is that why maybe is it related to the, would we have known from the take up of that what the take up of the COVID vaccine may have been? And what do we do to try and encourage people in those communities to get the flu jab as well?
Shall I make a start on those? I was just pausing because I was just getting the latest data up. So in terms of the likely coverage of this year's flu vaccination, Councillor Anderson, what happens every year is that there's a judgment made on the 3 strains of flu that are likely to hit us in the Northern Hemisphere, that is based on what's happened in the winter that's just happened in the Southern Hemisphere. The problem this year is there's been very little flu in the Southern Hemisphere because there's been very little mixing. So those judgments, people aren't quite as confident because they've had less to go on. So my latest advice from our colleagues nationally is that there's a reasonable expectation that there's a 50% protection from this year's three strains likely to be the strain that people encounter. So that's slightly lower than usual, but that's the latest advice we have. It's around that 50% mark. So that's that one. In terms of the uptake, we work with, so in terms of the uptake on the flu vaccination, we work with NHS England data that they break down into different population groups, and the data that we have is broken down into there's health and social care workers, there's pregnant women, there's the kind of school age kids, over 65s in different age groups. At the moment, the data that we get from NHS England doesn't include the ethnic background of people. We need to generate that data locally, which we'll do. We do get it on a ward basis, so we can obviously look at that at a very local level as well. So there is overall this year. Sorry, I'm just reading this. This has just come through today. So far this year, we've got a 41% uptake of everyone who's been eligible for flu vaccine so far, who've actually taken up the vaccine. And generally that's very high for the over 65. So in the over 65s, that's 85%. In the 50 to 64s, it's lower. It's around 70%. So as you move down those ages, like COVID, that you get a lower percentage. But I can certainly we do get a regular update on the take up of flu, and it is still quite early in the season, so people are still getting the flu invitations now. And of course this year it's the biggest flu campaign, so Sam can say more about it. This is the biggest flu campaign the world has ever seen and we've ever seen, because it's now for every single school child. Last year it was just up to year 7, so we've never done this before in high schools. But you know, my understanding is the high school rollout is going really well. I'm just looking at these, it's 70% school age at the moment, so, and that's through a nasal spray, not a vaccination for children. So we have, on that ethnicity, we have to generate that locally, but we do get the breakdown of the different groups, and we can certainly share that with the committee if you'd like to see that.
Thank you. Councillor Arif wants to come in.
Yeah, just briefly, it was timely. The Lord Mayor's car's just come in. Councillor, the Lord Mayor and I did we went to Chapeltown and got our flu jab done and did a press release on the back of that. And I think that was important for us, coming from an ethnic background and encouraging people from ethnic backgrounds. And I think it's a really important question. I think perhaps the awareness is there actually are our BAME communities getting the flu jab. And I think that anecdotally from what I'm hearing, I think there is more awareness there. I think we need to build on that. And I think as elected members and leaders across the community, we've got a role to play in that. But I do think it's a really good question. Thank you.
Okay, thank you, Councillor Hatbrook. And then Councillor Anderson, you can ask your third and fourth question. And then Dr. Bill, you can now ask your fourth question as well after she. That will be it from.
We've never had it so good. Two linked questions. One going back to something that was said a wee while earlier on, and one going back to the flu vaccine efficacy. So you said that the flu vaccine efficacy is currently estimated to be 50% effective. Is that based on efficacy against the known strains that we now know are going to be dominant, or is it based on statistics? Because actually, out of the 3 that we've got the jabs for, we know there's 3 plus X out there that may become dominant. So is it a known efficacy against the cohort of flu that is circulating, or is it because it's still quite early in the season and actually the efficacy is kind of erring on the side of caution? The second one, I may not be able to answer this, but you mentioned that there's planning being made for combined flu and COVID jab rollout next year. Is there anything further that can be said on that? Is there anything that can be shared, in terms of the obviously COVID eligibility and flu eligibility have misalignment between cohorts at the moment? Is the planning still at an early stage where you don't know kind of how that's going to work, or is there stuff that can be shared?
We don't know yet. This is quite a dynamic situation. So as soon as we know, I'll obviously inform people, but I don't know just yet.
Just on the first question, Councillor, it's based on the match. So where there is a match of the flu that we see circulating here with one of the 3 that's in, the efficacy is really high, but it's whether the match is right, if that makes sense. And the judgment, I mean, again, it's not my view that it's a 50%. Obviously, these are our colleagues in the new UK Health Security Agency. They give us a weekly kind of update on that percentage. So they might feel more confident next week when there's been more flu going around. So what they do is the small number of flu cases that we have currently in Europe and the UK, they monitor to see how much of a match they are with what's in the vaccine. So it's on that basis that the 50% judgment, but it does change week by week. Thanks.
Thank you. Before I come to you, Councillor Anderson, Councillor Taylor hasn't said anything, so I'll allow her ask a question.
Just following up on the flu job. Obviously, go back to 2015-16 when I was on health. We was on the corridors with flu patients. However, with the injection, this is the time it's rolling out. So it's hard to tell how many people, but what you have to balance, just forget about 2020 and go back to 2019-18 and see if those figures matching today, and it's around November time, you should have a better picture. It's a bit too early to say, but I know that Councillor Latti was quite right with his first question. We need to keep an eye on flu.
Thank you. Councillor Anderson.
Thank you, Chair. This will be a really quick one. Paragraph 43 in the report on figure 14. Should the statistics in the little table at the bottom, should that not say 2021? Because you've got the chart going from March 20 to September 21. But then in the little table underneath, you've got day by day, but it's got 2020. I don't know why we'd want to know 2020 out of all of
Councillor Anderson, I think you're correct. And I'm delighted that you've paid close attention to every figure, and we'll make sure that our data colleagues know that you've paid attention to every figure. Thank you so much. I think you're right. I think 2021 is a year that just never ended, and I think it probably reflects, to be honest, the fact that we feel we're still in 2021 because 2021 has never got away. But yes, it's complete. I'm sure you're correct. Thank you.
Thank you.
Now I'm very pleased I allowed you to answer your third question.
And the other one was in paragraph 44. Can you just update me on, or update us on the current position? Because obviously this report was written probably a little while ago now. So what is the number of beds occupied by COVID patients? Is it still as bad as it says in there?
There's 85
Yes, fine.
85 patients today, 8 of which are in our critical care unit. That's actually been a drop from last week. We had quite a spike a few weeks ago, which was a bit concerning, but we have started to see that number come down. So yeah, we've got 80, between 80 and 85 at the moment, and that will, our predictions, we do a 1 week ahead predictions just so that we make sure that we're ahead of the disease in terms of being able to place patients in a timely way. And that number looks as though it's going to continue to come down over the course of the next week, so hopefully just shy of 80 to 75. So, and I look forward to that day that continues to go down.
Thank you. Dr. Bill.
Thank you, Chair. I want to look back and then look forward. We know that basically the NHS was not prepared adequately for what has happened for the COVID pandemic. And Michael Marmot has told us that over the last decade of austerity, that certain groups, certainly inequalities increased, some groups were actually moving backwards, and the gaps were getting wider. And the NHS at the time, pre-pandemic, had tens of thousands of vacancies for doctors, for nurses, maybe for other staff groups as well. So what I would like to ask now going forward is, what's the current situation in Leeds in terms of the number of vacancies, unfilled vacancies of doctors, both within the hospital, and Tim's gone unfortunately, but also as far as GPs are concerned, what's the number of vacancies, unfilled vacancies for nurses? What other staff groups also do we face vacancies? And what is being done to improve the situation if those vacancies still occur?
If I may, so I will have to come back to you with the exact numbers, I'm afraid, in terms of the vacancies around both the nursing and the doctors, because I think it's only appropriate I get those numbers right. We are doing a huge amount around our recruitment. We have done an extensive international recruitment to support and bring in really excellent nurses and doctors as well from outside of the UK. There's a number. So that's some of the work we've been doing. I think where we have to get this right is actually in terms of the national workforce planning. So I think it's certainly from how we try and influence in Leeds with some of that work, the work that Julian Hartley, our chief exec, has done, and Linda Pollard, our chair as well, to try and influence some of that is really critically important, because if we don't start appropriately recruiting the number of radiographers that we need, the number of junior doctors that we need, etc., then this position is going to continue. So we are going to be, as an NHS, in this difficult position for quite some period of time until some of those workforce training issues are actually worked through. And I think that's the shame from before.
Thank you, Claire. Yeah.
Yeah, recruiting from overseas is fine. It depends where you're recruiting them from, because some of our recruits have been from actually countries where they are themselves short of doctors and nurses and are considerably poorer than this country. And I do have some concerns. And even within this country, if we get more doctors in our hospitals in Leeds, does that mean to say Manchester or Birmingham or wherever are getting fewer? So I think there's a much bigger global, national and global problem which needs sorting, but certainly workforce planning in this country is absolutely essential.
I would agree. Workforce planning is absolutely critical, and certainly the submissions that we make on an annual basis shows the whole time equivalency gap that we have, and that is submitted to the national team. We are very careful in terms of the point that you made around international recruitment and ensuring that we don't destabilise other vulnerable communities abroad. So I just would like to provide some assurance on that.
Thank you.
Yes, Helen.
Yes, I'm going to come back to you on the figure on the GP vacancy rate because my text has failed to elicit you an answer. I just wanted to re-emphasise. I think it's through the paper, but however many clinical staff we recruit, if the clinical capacity is occupied by people who need social care instead of that clinical capacity, then we need to just remind colleagues that we're working as a system, and that we really recognise that recruitment of other staff is as important, or possibly even at this point more important, because we can't admit patients to have that clinical care if we can't discharge them safely to their own homes or provide the preventative care that stops those people becoming unwell or unstable in the first place. So absolutely recognise that in order to do the elective recovery work that we all aspire to do to make inroads into the people who've waited too long, we need more of everybody. But I think the work that we're trying to focus on right now, as much as the clinical staff, which is certainly not going to stop, and the work that we're trying to do to recruit those staff doesn't stop, but I think it is really important that we're really focused now, particularly on home care staff and care home staff. So I think and Kath can maybe update on the vacancy rate for those, but I think it's in the round we wouldn't want as health colleagues not to be supportive of that issue.
Thank you. Councillor Gibson.
Thank you, Chair. Are you bridging the gap at the moment with agency staff? And of course, agency staff. So when you talk about vacancies, there are actually feet on the ground, if you like, delivering services. And if that is the case, are you receiving some financial support from central government? Because obviously to pay for agency staff, just because it's more expensive. Have they recognised that, and is that happening?
So where we can, we do use agency staff. I think at this moment in time, the funding isn't the issue. The issue is staffing, and we're looking at all different ways in which you can use different workforce. So making sure that we don't just focus on our registered staff, but also our non-registered staff, and increasing their roles, looking at a variety of roles, working with our third sector colleagues who play an absolutely vital role in supporting the statutory sector. So looking at all different ways of doing things.
Okay, thank you. Kath, would you like to come in, please? Thank you.
Yeah, I think it was very important that we actually do talk about social care. I know the NHS is a national obsession, but we are, as my colleagues have said, part of a system, and I have never known recruitment so severe in terms of a challenge. On one level, we had quite a good COVID experience to start with in social care in terms of workforce. When the country shut down, there was furlough. Social care was able to recruit really well for the first time in the 33 years that I have worked in the sector. And to give you an illustration of that, in terms of regularly supplying home care, we, at our best, had 21 people waiting for home care. That's the best I've ever known it. As of last Friday, we had 186 people waiting for home care, and that's 1,875 hours. We're getting handbacks, which is when agencies cannot recruit enough staff to provide care. We have situations where not only the support workers are going out, but the care coordinator and the manager are going out to deliver hands-on care. And what we saw when retail and hospitality opened up is those staff that we'd recruited during furlough and lockdown went back to those sectors. Those sectors have experienced recruitment challenges themselves and are putting up their rates of pay rather. So to work in a supermarket now, it's between £9.20 and £10.70, and you get 10% off your weekly shop, which if you are a low wage worker, which care workers are, that means a lot to you, and it's a heck of a lot stressful than working in social care. We have Amazon advertising at £10.40 with golden hellos of anything between £1,000 and £3,000, which are denuding social care rapidly. Social care workers do not feel as valued as NHS in the national consciousness. I still think everybody clap for the NHS, and by the way, brackets will clap for social care as well. And they've had a really torrid time. A number of them, particularly in care homes, are traumatized by the number of deaths that they witnessed of people they do love and care about. You know, we talk about care homes being like an extended family, and that's not just the residents, it is the staff as well. So it is really, really tough. And as much as we are struggling to secure home care, we're also struggling with care home capacity. So even though you look at something like Capacity Tracker, which is the national monitoring tool, on paper it looks like there's lots of vacancies. Actually, the care homes can't recruit staff either. So we're having real difficulty placing people, anybody with some degree of complexity, and that's usually people living with dementia. The care homes would choose not to. So if we look at the amount, some of the delays in the acute mental health sector, it's people with complex dementia who are waiting a very long time, which is distressing for them and for their families, because an acute hospital ward is not a good place to be if you're somebody living with dementia. So that's the sort of gloomy side of things. In terms of what we're doing about it, the government has given us a recruitment and retention grant. That works out in Leeds as a spend per head of £130, which isn't really going to get us that far. We have set up as a system a workforce task group, and we've been meeting at 8 o'clock every morning since last week, so it's nearly killing me, to go fast and furious on what we need to do. So we are looking at, we've got a staff mobility framework in place amongst the statutory organisations to see whether or not, when it gets really sticky, can we move staff around. We're looking at bank arrangements. So NHS colleagues already have a staff bank. Actually, the council doesn't. So we're looking to set up a staff bank within the council, because it isn't just hands-on caring roles, it's the ancillary roles as well. It's the cooks, the cleaners, the drivers that we need as well, and that the care homes and care agencies are struggling to get. We are looking at a talent pipeline through the Health and Care Academy, and doing a recruitment campaign we're going to gear up to do. We want this city to show its love for social care workers, make them feel valued, and try and attract them into social care roles. Now, as part of that, pay is absolutely key. And it's really positive that the government has put the national living wage rate for next year up to £9.50, and £9.50 this year is what the foundation living wage, the Real Living Wage Foundation has recommended as a real living wage. It's £9.90 next year. So we are talking as a system about whether or not we can bring forward paying that £9.50 now, because we really need to go out with an improved offer for permanent wages, not just bonuses to stay, loyalty bonuses. I don't think that will be enough, not when I'm competing with Amazon offering thousands. So we want to be able to do that. And then we're also looking recurrently into next year whether or not, as a system, we could find the money to put the wages up beyond £9.50, beyond even £9.90. We need to pay, I think, a minimum of £10.50, ideally even more. We've talked about international recruitment, and we in social care are trying to piggyback on the back of that to look at recruiting social care nurses, because in other parts of the country, not in Leeds, but it's maybe only a moment of time, nursing homes have deregistered as nursing and just dropped down to being residential care because they cannot secure nurses. And I would say nursing care in Leeds, we have just about got enough, and we would really rather like to have some more. there is no give on this at all. And if we don't have enough nursing homes, then hospitals will really get backed up quite rapidly if they're not already. You will be aware we have in-house our own We Care Academy, so that's recruiting entry-level people into social care. We do the training and then they're guaranteed a job interview. So it's a really important pipeline. We are looking at using social media to recruit rather than, and as well as roadshows, because talking to care providers, social media is where it's at now. That's where you get your success. So looking at Facebook feeds and things like that. And then we want to double the intake we're able to take through the We Care Academy so we can get that pipeline going. And that's just some examples of some of the things we're doing. We could have really done with starting this 3 months ago, but you know, we are where we are. But I think this is going to be a really challenging winter.
Yeah, thank you very much for that, Kath. Still talking about workforce crisis. Obviously, the government announced last week about frontline staff who have not been vaccinated will not be allowed to come back into work. How are you going to deal with that gap? Because there are so many of them. I mean, I don't know in terms of, have you got figures? Where do you think we are in Leeds with that announcements, and how many frontline do we actually have that will have to leave their jobs? And what is the plan to replace those who would be sent home?
So I can give you the figures on care homes. Again, this is drawing on Capacity Tracker, which relies on homes to input the data. So just looking at care homes, the latest printout says there's 458 staff out of 5,966 in a care home who are not double vaccinated. Having rung round the care homes, we talk to them daily, if not weekly. We think that the figure is better than that. We think there are fewer unvaccinated, and so far the homes have said 16 staff have left. So we're going around doing a further validation of figures. We only had 3 care homes where vaccination was around 70%, and those care homes had very clear recruitment plans well in advance to replace the staff that they were going to have to let go. So at the moment, I'm cautiously confident of stability with our care home sector. With home care, the numbers having the first dose is 86.32%, numbers with second dose 82.02%. So a way to go. Now, the implementation time for this, we've got a longer lead in. The government are talking about the sort of cut-off date being in April of next year, because I think ourselves and health colleagues are all saying we cannot afford to lose any staff over winter. Please give us a longer lead in. My view is that there are bound to be people who will not want to get vaccinated and will leave care completely. So we had people leaving a care home but going to work in home care or supported living. Those people will leave completely. And I do not know what the government's plan is to replace those workers, because at least the NHS has a workforce plan, even though the figures might not be right. Social care nationally does not have a workforce plan. So you have to come up with your own solutions, and it has to be better paying conditions for care workers.
Yeah, so to date, we have really concentrated on promoting the taking the vaccine rather than requiring it. So I do believe that over the next few months, we will see some people who have been a little bit later in making that decision to have the vaccine, they will take it. And some people will look at the consequences and feel that's what they need to do. We will work with people in as compassionate way as we possibly can, trying to understand their reasons for not wanting to take the vaccine, see if we can give them any assurance to make that decision. But at the moment, I'm expecting that we will get some national guidance as to how we deal with this as a whole NHS, because I feel for us to put different systems in place between trusts is the wrong thing, so that people feel that they can hop between. We need to have one way of doing this, and we await that guidance.
Thank you, Sam. Councillor Harrington.
Thank you, Chair. It's just a suggestion for Kath, really. I don't know if you've ever heard of an organisation called Tempus Nouveau, who are actually based at Leeds Prison, and they've been doing fantastic work all over the country, really, and they've won some awards recently as well, in actually recruiting ex-prisoners into workforces. So there may well be some white-collar crime people who would not be a major risk to be risk assessed to work in social care, but actually giving them an opportunity to start doing that before they leave prison. And there are several prisons within Yorkshire and Humberside that are actually working with Tempus Nouveau at the moment. And there are some women's, got 2 women's prisons in Wakefield and at Askham Richard. So it may be a possibility to start recruiting in those places too. Thank you, Chair.
Thank you very much. I have another question. It's regarding vaccination. So maybe Councillor Arif, are we given, so if someone has had Pfizer 1 and 2 and the booster, do you need to still have the same, or you're okay to have another?
I think, Victoria can come in perhaps, I got Pfizer. So I think it's Pfizer that's out there at the moment, if that, and Sam perhaps will probably know better.
You can have another.
Yes, I'm
A
triple
mixture.
jabbed with the Pfizer. So I've got 3 Pfizers. So I've had first dose Pfizer, second dose of Pfizer, my booster was a Pfizer as well.
So you've had the same?
Yes.
I'm asking if you can have a different one.
Oh, okay. Yes.
Yes,
Yes,
you can.
yes.
You had a different from your 1 and 2. Yeah. Okay.
Yes.
Fabulous. And you're alive. Excellent. Right. That's
I
fine.
hope so.
Yeah. Okay. And then I think my last question, right. So when patients are taken into hospital, that's not COVID related, and they're sent home, are they tested before being sent home? Because we've had reports of some patients who have come home and have come back home with COVID. So do you test all patients when they're leaving hospital, especially patients that didn't attend due to COVID?
So if there's a likelihood of admission, then we do test all patients, but we're not routinely testing every single patient that walks through into the emergency department. No.
No, when they're leaving hospital, so you've
Oh, when
admitted,
they've been
so
admitted
someone's
and then
come to
they're
the
going
hospital for a completely different illness.
Yeah.
And when they're discharged,
yeah,
and they get home, they now find out that they now have COVID, and they
Okay.
were not told that whilst they were in hospital.
So we are testing at presentation day if they've been admitted, day 2 and day 5. So we're doing that routinely just to ensure that we manage our risk of nosocomial infection. If a patient is then going on to a care home or a residential care or somewhere like that, we are testing all of those patients before they leave, so that we have a clear understanding of their COVID status. But if a patient is just due to go home and they're outside of that 5-day testing and they're not demonstrating any symptoms or anything like that, no, we're not routinely testing them before they go home.
Right. Yes, Councillor Cunningham.
Thanks, Chair. I was just wondering, Kath, you mentioned about some nursing homes lowering and becoming a residential home. What is happening to the residents from the nursing homes who've clearly been assessed as needing nursing care? Thank you.
Well, just to stress that's not happened in Leeds. It was Hull that I know where it was deregistered. They have to be, there's a protocol for a home closure. Well, or in this case, it's a deregistration of the nursing element. Those, the home would notify CQC, they notified the local authority, they work with the home to assess the individuals and move them to other provision.
Thank you.
Okay, any other questions? That is very good. Okay, we will now move on to agenda item 9. Over to you, Angela. You're not allowed to go yet. Just give us 2 seconds. We've got some thank yous to do.
Thank you, Chair. Item 9 is the work schedule. So this report relates to the board's forthcoming work schedule, the latest version set out in Appendix 1 for members' consideration. This report also references the Scrutiny Board's discussion last month in relation to the plans for redesigning the community neurological rehabilitation service in Leeds. A written statement setting out the observations, the conclusion and the recommendations of this Scrutiny Board was subsequently produced in consultation with board members and was submitted to the Leeds Community Healthcare NHS Trust and NHS Leeds Clinical Commissioning Group. And so a copy of this statement can be found in Appendix 3 for information. So I'll pass back to you now, Chair. Thanks.
Thank you very much. Our next meeting is a budget working group meeting. So really, this is our last formal meeting of the year. And I want to use this opportunity to say a very big thank you to each and every one of you, especially all of you from the NHS, for all your hard work, sacrifice. And I mean, can we just give them a hand of applause, please? Been a very tough 2 years, and 2021 obviously we saw some light, you know, compared to where we were last year, and we're still trying to break through the difficult times, and without your help we will not be where we are. So we just want to say thank you, and on behalf of the board, for all your help. We still have lots of questions and lots of scrutiny, but we're in this together, and we really hope that 2022 will be a much better year for us than 21. So thank you from the bottom of our hearts. If we don't see you before Christmas, you all have a very Merry Christmas and stay safe with your family. So thank you very much. And if you've not had some pies, we've got some mince pies, please do help yourself to one before you leave. So thank you, everyone. Thank you, everybody. Thank you. That's the end. Oh, yes. Awesome. Councillor Kidjo wants to say
this
something.
is just a message to Kath.
Oh dear.
Sorry. to Kath, actually. I lost a brother in a care home to COVID, and I have to agree with you. The care that he got from those care workers were fantastic. We have been in touch and we have been going in and trying to support them as much as we can. But I do understand what you're saying, because we're hearing this from the care staff. You know, it is hard. And when you think about, and I'm not dissing the NHS, please don't think I am, but when they work in a care home, they get to know the people and they feel the loss as much as we, the family, do. So I just totally understand where you're coming from, but can I just say, fantastic job, thank you.